Thank you for joining iMeet. This meeting is now being recorded.
Happy Monday evening, everyone, and welcome back to our AABIP webinar series. I'm Ara Christian, coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harbor, UCLA, we're excited to bring you back to another highly relevant talk today. But before the formal introduction of today's topic and speaker, I'd like to review a few housekeeping matters. First, everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and, of course, optimize the overall listening experience. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions, communicate with the group, or interact with the speaker during the webinar, please utilize the chat box. This can be accessed by clicking on the thought bubble icon located in the bottom left of the iMeet window. Now, we will keep track of the questions as they come up and address them toward the end of the hour in a formal Q&A period. So please feel free to type questions in at end. Now, also in the bottom left is a projector icon. This allows the audience to toggle between the presenter slides and any videos. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shaw for our formal introductions today. Dave?
Thanks, Ara. So today we are very fortunate to have the topic of pneumothorax and the management of bronchopleural fistulas. And obviously, as Ara had mentioned, this is very relevant to many of our practices. Today we are pleased to have Dr. Colleen Keys join us, and she is the co-director and chief of operations of interventional pulmonary at the Massachusetts General Hospital over in Boston. So Colleen, thank you so much for taking the time today out of your busy schedule to talk to us about this topic.
Great. Thanks for inviting me, Ara and David, and happy to participate. I believe we're going to try to answer some questions at the end. Certainly, I'll help as I can. We'll try to keep it relatively short so we have enough time for some discussion, because I think it will actually generate some interesting discussions. I have no relevant financial disclosures. Today we will talk about treatment plans for both primary and secondary spontaneous pneumothorax. We'll define the bronchopleural fistula, discuss the quantification and measurement, and how that may be relevant to management, and we'll debate various managements for the persistent air leak. I wanted to start with a case. This is a 34-year-old man who presented to the ED earlier this year with 2 days of pleuritic pain he had experienced at the office. And it may not project very well, so I just wanted to draw a line on where the lung marking, the pleural line, is here. So my next question is, what would some of you do next? Do we insert a chest tube, admit him, or send him home? Would you consider solely aspirating and sending him home, or aspirating and observing him? Leave a little time if anyone wants to put any answers in the chat box. We see what type of consensus we might have.
Dr. Keys, looks like a few C's and a D.
Yes, and a D. So it seems that most people would do some type of aspiration, and most would admit him. We have a few send homes. So what do we know based on guidelines from CHEST and from the British Thoracic Society? Well, I think first we just want to categorize the pneumothorax itself. If we're talking about the difference between a small and large pneumothorax, where the difference in treatment management comes up, you want to make sure you're defining what a large pneumothorax might include. With chest, you're looking at the apex to cupola distance, and the British Thoracic Society is looking at the lateral distance from the hilum to the chest wall. For primary spontaneous pneumothoraces, CHEST will typically advocate for observing small ones in the ED. You can discharge them if there's no progression. Stable large pneumothoraces, or obviously not surprising, if the patient's unstable, they recommend hospitalizing with a chest tube. And then the British Thoracic Society differs a little bit. It doesn't really show up here with this particular slide, but in small asymptomatic pneumothoraces, they'll typically recommend discharge, not necessary to observe in the emergency room in their guidelines, and then for any large pneumothoraces, they would recommend similarly hospitalizing with a chest tube. CHEST doesn't recommend needle aspiration. There is some variable success with that. I believe in Europe, needle aspiration is advocated a little bit more strongly, and there is some success to offer that as a potential treatment. The failure rate tends to be a little bit less than 50%, so you have to realize you're going to be dealing with some people who may have some recurrence. So I think typically in America we're offering some type of chest tube if we're actually going in with a needle. Heimlich valves may be helpful as well. If you have some type of chest tube in, there are some mini aspiration drains that you can put in so that the patient may be able to go home. Mini chest tubes tend to have a little bit better success than just needle aspiration alone if you're looking at complete expansion. And randomized controlled trials showed no significant difference in need for repeated procedure depending on which one you use. Let's go back to the case. This gentleman, you can see over here, we placed a small 14 French chest tube, a pigtail catheter, and now he has a small residual here. I'm just marking it with my pointer. Apical component was measured at 3 centimeters. If the tube is removed, how long will the pneumothorax take to resolve? And if you wanted to type, there we go. We have a few answers on how long this will take to resolve. So it looks like most people have selected either A or B. In measuring the pneumothorax, there are a few methods you can employ. There's actually some nice online calculators that I like to use when I'm not remembering this formula exactly, word, letter for letter, but typically you're looking at measuring the pneumothorax either at the mid-hilar level in the light method, or taking measurements at both the apex, the upper hilum, and the closer to the diaphragmatic recess. So this one, that particular case, would have been about 12 days if you go by that measurement. If you see in that prior x-ray, he really didn't have any lateral component. So if you measure A as 3 and you measure out the percent pneumothorax, you're looking at something that would probably be at about 12 days to resorption. If you're assuming that the pneumothorax had resolved, and you're assuming about a 1.5% resolution per 24 hours. Sometimes that can be improved with the deliver of higher flow oxygen that sometimes may speed up the resorption. As far as how we manage, in general, not unlike managing pleural effusions, we found that smaller bore chest tubes are just as fine for most cases as larger surgical chest tubes. The suction application, depending on who you ask, that differs a little bit. Typically, water seal is fine for most primary spontaneous pneumothoraces. If there's no re-expansion, typically here we'll apply suction. The British Thoracic Society typically recommends against suction for the concern of reproducing problems with alveolar leaks. So typically they'll say most cases should be managed with water seal alone. And then as far as discussing recurrence rates with your patients, it's important to let them know that it's not the most common, but it can occur in quite a range of patients. You're looking at somewhere between 17 to 54% in the first year after a first event. And then let's talk about secondary pneumothoraces. This gentleman I saw a few years back, 74 years old. He had a smoking history. You can see he has some emphysema. This was actually a third episode, this particular CAT scan, after a recurrent spontaneous pneumothorax. You can see here he has the beginnings of a mass in the mediastinum, probably an enlarged lymph node. We actually never were able to sample it as he had opted for fairly conservative management and didn't want diagnostics performed. So the question here is, what would offer the highest success rate, all comers, against recurrence of pneumothorax? Are you looking at something where you just drain alone? Would you offer some type of surgery with talc pleurodesis? Would you insert talc through a chest tube? Or would you insert doxycycline through a chest tube? It looks like we have mostly Bs. Some would opt to provide talc pleurodesis through the chest tube. Well, there are some guidelines that, again, both CHEST and British Thoracic Society offer for secondary spontaneous pneumothoraces. To remind us, these are the management guidelines for primary spontaneous. And then in comparison, when you're looking at secondary spontaneous pneumothorax management, they'll typically recommend that most people should probably not be going home once you see it. Even if there's a small pneumothorax, chest will typically recommend at least some observation, even if you're not putting in a chest tube. Same as British Thoracic Society suggests all patients should be admitted to hospital. Again, putting in chest tubes, small bore is acceptable. Large air leaks can be tricky, and some might recommend larger air leaks just to keep up with the rate. In terms of what you might offer, after a secondary spontaneous pneumothorax, most societies will recommend after a first episode, you really should be thinking about some type of prevention. And most of the time, they'll recommend either chest tube pleurodesis or surgery. They'll recommend surgery over types of pleurodesis. But again, it depends a little bit on what the patient's surgical comorbidities might be. In looking at different types of medical pleurodesis, there is some good data that suggests doxycycline has good success. Most of these cases are looking at subsets of patients who were treated either for malignant effusions or for malignancy-related pneumothoraces. Here you can see there's fairly good long-term success in small trials. And like I said, surgical pleurodesis tends to be preferred, but not everyone can tolerate surgery, especially as the population ages. Intrapleural tetracycline, there's a fair amount of data looking at this particular agent for pneumothorax in particular, and there's some variable response rates. In general, you're probably looking at, based on the studies, anywhere from a 40 to 60% success rate. Talc is best studied in malignant pleural effusions, a little less in pneumothoraces, but there is data to suggest it could be helpful. Most, though, have studied tetracycline and doxycycline in looking at pneumothoraces and their treatment. There's conflicting evidence on how well it can be used in persistent air leaks, and most believe that using larger doses is really better than using a small dose. The problem with that, the offset, is that you're going to be dealing with a higher incidence of pain. However, you might consider giving some lidocaine beforehand, intrapleural, and then obviously some type of IV or oral medication for pain before you instill the agent. There's no controlled studies specifically looking for response rates in pneumothoraces when you're looking at talc or doxycycline. But like I said, in general, most of the studies have looked at either tetracycline or doxycycline. So say you offer one of those and it fails, well, what do we do then? And unfortunately, there's really no guidelines beyond this. There's several agents you could go to if one of them fails, and these are looking at the agents used in malignant pleural effusions, but you could consider any number of those as well. In looking at extrapolating information we might have from preventing recurrent pleural effusions, you could consider using alternative agents, as in this study where they used doxycycline after talc So if you're continuing to fail, what guidance do we have on what we might do after this? When we look at the natural history, that can sometimes help us, and I think what's important to think about when you're going to consider what method to try to reduce your air leak, your persistent air leak, one of the important factors is looking at the duration of leak. Now, most leaks, when you're talking about a primary spontaneous pneumothorax, most of those will resolve within the first week here. You can see this graph that 50% of people in this study had a resolution, spontaneous resolution of a persistent air leak after 1 week. And then you compare that to diseased lungs or secondary spontaneous pneumothorax, where you're looking at a much longer time period to at least 50% resolution. And then this trails off, and you can see a higher percentage of people take much longer to resolve compared to somebody with a primary spontaneous pneumothorax. The other part of this is figuring out what you're really going to call your leak. Obviously, you're looking at a very large defect in the left main stem here, and I think few would argue that this would certainly be qualified as a bronchopleural fistula. This as well, if you have an obvious leak from a large airway, and what we'll sometimes do is drip saline onto surgical stumps in order to determine whether there's a leak. But then beyond that, it gets a little bit tricky. Do we call this a bronchopleural fistula? This is a gentleman I saw over the summer who had terrible disease from a pneumocystis infection, and it was complicated by mycobacterial disease. So do we call this a bronchopleural fistula? There's a small distinction, but I think it's important to point out that there is a slight difference between a bronchopleural fistula and an alveolar pleural fistula. The general umbrella term certainly would be a bronchopleural fistula. However, the alveolar pleural fistula really is specifically talking about a defect of the pulmonary parenchyma that's much further than the segmental bronchus, and that's communicating with pleura. It's an important distinction because I think we may treat things a little bit differently, although there's really not a lot out there when it comes to guidelines here. I think when we're talking about smaller alveolar pleural fistulas, it may be worthwhile to consider some of the non-surgical methods or consider endobronchial methods as a bridge to thinking about eventual surgical treatments if needed. I think most large bronchopleural fistulas, ideally, if you look at some guidelines by chest, will typically suggest surgery as a first method, and then using endobronchial methods if the patient really isn't appropriate for surgery. Going back to talking about some things that may help us determine what type of intervention we might offer, part of this, again, is determining the length, like I said, and part of this is also talking about how large the leak is. This is a diagram from the Atrium Oasis chamber. Many other companies use water-sealed chambers that look very similar. And you'll see these marks here, 1, 2, 3, 4, 5, and that's really trying to quantify the leak. So you'll see the bubbles come through this water-sealed chamber, and the larger the leak, the closer you will be to 5. But it's a fairly crude measurement. You can also measure it by thinking about when in the respiratory cycle the air leak is occurring. So in this model, you're looking at whether it's a continuous air leak down to the lowest grade, which is an air leak that's only occurring with forced exhalation or cough. So when you're doing your daily notes, it may be helpful to quantify things looking at what's happening with the leak as the patient's breathing. And then to even get more fancy, a little bit more detailed, actually digital chest drainage systems. This one is called Topaz. That's the fairly common one that's out there now on the market. This is really giving you a more detailed view over time, and it can graph things over time of what the flow is. So I'm going to show you here another diagram from the system right here, showing you over hours, over the last 24 hours, what's really happened to the flow. This will give you a little bit more detail as opposed to a once-a-day visit or a twice-a-day visit, where you may see a leak if it's certainly large enough, but you may not. It doesn't necessarily mean that it's completely gone. It just may be over time. One snapshot in time is not giving you a very detailed feedback on what the leak is doing. So the digital drainage can certainly also maintain the pleural pressure. That can be important, especially when you're at water seal, because in the traditional drainage systems, the pressure, intrapleural pressure, will be affected by the fluid in the tube. It will also be affected by the level where the device is in relation to the patient. The nice thing about the digital drainage, like I said, it will measure airflow over time, which can be helpful in determining when you're ready to remove the chest tube. And there actually has been a randomized trial looking at these Topaz systems in relation to a traditional drainage system. In general, they found that most patients were able to have chest tubes removed about 1 day earlier, and air leak duration was shorter, they believe, because the pleural pressure was kept at a steady rate no matter where the device was in relation to the patient. They also found here in this randomized study that there were less prolonged air leak cases when you were using the Topaz system compared to traditional drainage. And overall, otherwise, the populations were quite similar. These were all post-lobectomy patients that they were looking at. So now we've got how you're going to quantify it. Well, if you're going to think about some type of localization, there are a few methods you can employ. Most typically, people will employ using balloon occlusion, and that's done by flexible bronchoscopy. There are a few other methods. Some of them are a little bit dated, but people will still use capnography, and that would entail putting some type of catheter into different airways, making sure the chest tube is off suction, and you slide a catheter down that's connected to some type of capnometer. The idea is the leaked area will actually not be returning any entitles. So that's how you're able to localize it a little bit. Bronchography can still be used, although this is somewhat of an older technique. Some suggest if you have a very intermittent leak, it's something you might want to think about using. And scintigraphy, some type of ventilatory radioactive technique, can also give you some sense of where a leak is, although most of these patients we're dealing with probably have underlying lung disease, so it could be less sensitive in those instances. And there was actually a small case series looking at intrapleural instillation of methylene blue as another technique as well. It can be a little bit more difficult to localize a leak that may be coming from several areas. And as you can imagine, after the medication was delivered, if the patient was considered a surgical candidate, it was a little bit more difficult for the surgeons to really find their way and find the location they needed to target. So the recommendations, like I said, typically surgical closure after 5 days, where we would consider something a persistent air leak by guidelines. True bronchopleural fistulas ideally would be reinforced and revised by the surgeon. That may include grafts from muscle, from omentum, and other areas. It may include, particularly if a patient is less of a surgical candidate, a chronic open drainage, something like a flap where you would actually allow for extrathoracic drainage, and you can pull the muscle flaps into the pleura. And then mechanical pleurodesis, as I discussed prior. Beyond that, there's really not a lot of guidelines. Post-surgical, when we're looking at bronchopleural fistulas, they tend to be higher with pneumonectomies, although it's quite a large range. They're more common on the right side, and not surprisingly, they occur more frequently with malignant disease that may be complicated by either radiation or chemotherapy. So there's quite a long list of things that people have reported using. We really don't have any head-to-head trials. Some people have used many of them. Some of us have one particular method that we gravitate towards. Again, unfortunately, we really don't have any guidelines here, and I think it would be interesting to see in the next years if we can come to some consensus on what some of these may be better than others. When we're looking at different types of sealants, and I'll just go back quickly again, we're talking about most of these here in the first column, all the way from fibrin glues to more permanent cyanoacrylates. They'll often cause granulomatous reactions. With fibrin, that will typically resorb somewhere around a couple of weeks. Long-term scarring is less common, but if you're looking for something that's a little bit more permanent, fibrin may not really be your best choice. Scaffolding definitely helps. Any type of sealant I'm putting down, I'll typically put in some type of scaffolding. I'll use cellulose, calf bone, spongy calf bone has also been described. And care should really be taken to avoid contact with your working channel because it could destroy your scope. All right, David, I think we're ready for the first video. This was a pneumothorax in a persistent air leak in a patient with esophageal cancer who had had a lobectomy, and it just didn't seem to want to close there in the right upper lobe. We can go to the next one. So the next video here is showing us using a balloon catheter. We'll actually snip off the edge, so then you have two working channels to deploy this particular glue. This is a cyanoacrylate glue or bioglue. And you need two working channels because they're essentially an epoxy where you lay down one of your agents and then the next one will lay on top of it, and that's when the cross-linking occurs. We can go to the last video. and this was after the glue was laid. You can see here, you really don't see the leak any longer, and this closed the persistent leak. That was courtesy of Dr. Folk. All right, and we'll go over. So what about valves? Certainly we can use valves. They're off-label, but there is a humanitarian device exemption for the spiration valves in the U.S. Both spiration valves and Zephyr valves are used internationally for persistent air leaks, but if you're in the United States, only spiration valves are approved. Overall success, fairly good. Again, not much above some of the other methods we've discussed earlier, particularly the medical pleurodesis. Time to resolution, typically around a month, so we're not removing those valves before then, typically. And we typically give a little bit of a window, a little bit of a cushion to make sure that you're removing it once the leak has resolved, once the pleura has adhered itself, and then we're also making sure you're not waiting so long because these can actually epithelialize. If no one's seen this before, I just wanted to show a video of the endobronchial valves being deployed. Quite easy to deploy. You can actually do this with a flexible bronchoscope. And there's a loading catheter provided by the company. And you deploy them with the catheter quite easily. They're also removed very easily. You can see that little post. They come out in about 2 minutes each one. And what they're really meant to do is prevent air from entering the segment as the patient inhales, but it's also somewhat flexible, and the idea is that you're providing a way for mucus drainage, but you're preventing the air from getting back into that space, and you're essentially inducing a segmental collapse with each segment that you occlude. Again, retrospective data shows fairly good success. It's somewhat variable. And the use I talked about. So in summary, searching for secondary causes of any pneumothorax will change your management. So I think it's important to make sure that you're excluding any secondary causes, interstitial lung disease, anything that you might be missing in a patient that comes into your clinic or comes into the hospital with a pneumothorax. There's some tools to suggest which pneumothorax and air leak patients will require further management, and that goes to talking about how you quantify your air leak, how long it's been present, and what the rate or volume is. Surgical and non-surgical approaches to the leaks, I think, should be collaborative and oftentimes can play off of one another, especially for difficult cases. And management of both alveolar and bronchopleural fistulas would benefit from some further detailed evidence-based guidelines beyond offering just surgery or mechanical pleurodesis. That concludes the formal slide set. I think we'll just launch into some questions.
Great. Thank you, Dr. Keys, for really a nice overview of the approach to management of BPF. We've got a couple questions. While we wait for maybe one or two more, perhaps I'll get things started. A fairly common situation we run into as interventional pulmonologists is the non-surgical patient with a persistent air leak and an incompletely re-expanding lung despite good chest tube drainage. I guess I'm wondering, maybe a two-part question. Number one, do you aim for a minimum target of lung re-expansion to help optimize success with pleurodesis? And number two, how and when do you incorporate autologous blood patch in these patients, given its relative ease and cost effectiveness at the bedside despite a relative paucity of data?
Well, I think in response to the first question, I typically will employ the classic measurements for determining whether I'm going to accept a less than satisfactory lung expansion. So typically somewhere between 2 to 3 centimeters is what I would be comfortable with allowing as I go to starting to peel off some of the drainage and determining whether or not I would employ any of the endobronchial techniques somewhere around 2 to 3 centimeters if it's not going to be complete expansion. Although, again, when you end up with less expansion, I think anecdotally, I think you really have a lot of troubles with a single method of trying to stop the leak. And then the second question was, remind me again, Eric, what'd you say?
When and if you incorporate autologous blood patch into the management of these patients?
So I actually have not used it. I have a little bit of a fear for the infection risk. It is used very commonly. I just personally don't use it. Typically, seems like you can add probably about somewhere between 50 to 100 milliliters of blood. And I know it is used. I just don't personally use it.
Great. Thank you, Dr. Keys. Do have a couple questions here from the audience. The first one is asking about the incidence of acute lung injury with talc or doxycycline for secondary pneumothorax. And is this concern heightened, and should we change our approach in patients with interstitial lung disease?
Well, as we know, the use of talc has been associated with ARDS and lung injury. In general, those events are much lower with the graded types of talc that are really being used today. Even in the U.S., we don't use the talc that was more classically associated with ARDS. So really in the most recent reviews, at least when you're talking about the use of talc in general, I don't think this was specifically looking at the pneumothorax patients, but in general, the risk of ARDS is typically below 1%, I believe. Now, there's some theory that if you're using it for a pneumothorax patient, you may deposit talc in areas that you weren't really intending to. So I think in general, traditionally, most societies have recommended using either tetracycline or doxycycline, where the lung injury incidence is really not there, but you're dealing with quite a bit of increased pain.
Okay, thank you. Another question regards a pretty practical situation we run into: air travel after the definitive management of pneumothorax. What are your recommendations?
So interestingly enough, the recommendations that we employ are really based off of one retrospective study that was looking at patients who went on an airplane before 2 weeks and after 2 weeks following resolution of a pneumothorax. And what they found was that a greater proportion of the people who went on a plane before 2 weeks required repeated management for pneumothorax. Now, it was a fairly small series of patients. So in general, we say about 2 weeks if you can get to it. I think it also depends on the length of the air travel. So typically I'll say if you're flying, 2 hours or less, I'm a little less worried about patients going in within that 2-week window than if they were, say, flying for 10 hours, or the longest flight now to Boston is Boston to Hawaii. So I don't know if I'd really recommend that before 2 weeks.
Okay, fair enough. Another question from the audience. Is there any data about persistent air leaks in long-term mechanically ventilated patients and the use of the veno-venous ECMO to provide low tidal volume ventilation to help with air leak resolution?
That's a good question. I actually am not aware of any trials looking at that. We use ECMO fairly frequently here. We haven't employed it for large persistent air leaks, so I'm not aware of the data, unfortunately.
Yeah, I haven't heard of data on that either.
Right.
If anyone else in the audience has any thoughts. Another question from the audience. The humanitarian device exemption for endobronchial valves recommends a removal within 6 weeks. In your talk and in the data that you reported, mean removal was much longer. I believe it was 138 days, mean removal time. Yeah. What are your thoughts on that?
Well, I believe the data I presented was really off of the post-marketing trial. I'm not sure why they have limited it to the 6 weeks. I'm actually not sure. That's actually a very good question. I would say in general, the longer you wait, the more risk you are for epithelialization of the airway in front of the valve. So certainly 6 weeks is around the time you'd like to, certainly.
Have there been increased reports of complications in those individuals who do have a longer indwelling time of the valves?
I don't think there's been any specific reports. I think some of the original trials looking at lung volume reduction, the longer they saw the valves in, you'd see some epithelialization. But beyond that, beyond some very early problems with potentials for post-obstructive pneumonias, I'm not aware of any long-term complications beyond the epithelialization.
Okay, and it looks like one more question that was there a second ago. Oh, there it is. That actually is related to the previous question of ECMO, but the use of oscillatory ventilation with pneumothorax.
I did, we actually don't have any experience doing that here, but I did read that. I think that was in, I believe Roberto Casal's paper had written quite a bit about that. We don't have any experience here at Mass General with that.
Okay. No experience with high frequency?
Not in use for persistent air, no.
Okay. All right. Those were excellent questions, audience. Thank you. And Dr. Keith, thank you once again for really a great overview. If there aren't any further questions, I'm going to turn the mic back over to Dr. Shaw for final announcement. David?
Great. Thank you, Ara, and thank you, Dr. Keys, again for lending your time and experience on this topic for us. By way of a couple of announcements, I want to alert the audience that our next webinar will be on December 12th with Dr. Tim Mergu, who will be talking about management of non-malignant central airway obstructions. And then also, as can be seen on the screen, please keep your eye out for announcements about the second AABIP convention, which is now scheduled for August 15 to 17 in 2019. So that'll be a very exciting time. So we look forward to having as many of you as possible participate and attend that conference. So thank you very much, everyone, and have a wonderful evening.